Now we are going to start on cerebrum. Cerebrum, we will see the developmental stages and then the details. You will find we got a question. There is a patient who has meningioma, and that meningioma is on the left side. Now understand, if the lesion is on the left side of the cerebrum, the problems, the clinical feature will come on the right side of the body. But if you say right side of the body will have clinical features, I have got 3 of the options available. Which one is my answer? Read the question again. Left lesion on cerebrum, right side of the body, but I have 3 options, and read the question again. You'll find that there is a homunculus given, which is paracentral. And remember, paracentral homunculus is controlling the lower limb on the contralateral side, also part of pelvis perineum. If you say paracentral lobule is the homunculus controlling the lower limb on the contralateral side and also the pelvis perineum, you mean to say this is the answer? Yes. Why that is the answer? We'll find out. But this is the answer. Keep the answer. But why this is the answer? We'll find out. And now we are looking at the cerebrum, showing some sulci lobes. Actually, during development, do you remember the cerebrum became C-shape? And when the cerebrum was becoming C-shape, it was actually developing some. See, this is the C-shape of the cerebrum, and it will develop some lobes: frontal lobe, temporal lobe, parietal lobe, occipital lobe, and some sulci also. Because you are looking from the lateral view of cerebrum, this is lateral sulcus, and on the lateral view there is a central sulcus also. So central sulcus, lateral sulcus seen from the lateral view of the cerebrum. Why do you need sulcus? To increase the surface area of cerebrum. That is the purpose of developing sulci. And what is on the middle side then? See, lateral surface, you see lateral sulcus and also the central sulcus. But if you look from the medial side of the cerebrum, there is calcarine sulcus. And on the medial view of the cerebrum, when you see calcarine sulcus, that is the area where you have occipital visual cortex. Occipital visual cortex. So we'll continue with that. But first you look at the lateral view of cerebrum, then you see the medial view, and you find this is the lateral view of cerebrum. You'll find that we were talking about a central sulcus. Remember, it is running anterior-inferiorly. As the central sulcus is running anterior-inferiorly, it is separating the 2 lobes. There is a frontal lobe on the front, and behind is posterior parietal. So parietal is posterior, this is the posterior parietal, and on the front is the frontal lobe. This is here separated by the central sulcus. Then you have got one more sulcus, which is the lateral sulcus, seen on the lateral view of cerebrum and separating the temporal lobe inferiorly. If you're telling that it is separating the temporal lobe inferiorly, what is it separating temporal lobe from? From the first 2, which is the frontal and parietal. So frontal and parietal separated from the temporal lobe by the lateral sulcus. And then you'll find one imaginary line drawn here. What is this imaginary line drawn here for? It is to separate the occipital lobe posteriorly. If you say this is the occipital lobe posteriorly, then where do I start drawing this imaginary line? That is started at the, yes, that imaginary line is started at the, where? At the parieto-occipital sulcus. So at the parieto-occipital sulcus, you will start an imaginary line, and then behind that will be the occipital lobe. Now we need more information of the cerebrum, and we are looking at this diagram. This diagram is similar, but with more details. You'll find again this is the central sulcus running anterior-inferiorly. Now if this is the central sulcus running anterior-inferiorly, it was separating the 2 lobes, and you will find now there is a precentral gyrus, frontal motor cortex. If you activate the neurons, some muscles start moving in the body. Face muscles, upper limb muscles, lower limb muscles. These neurons are frontal motor cortex neurons to control skeletal muscles of the body. Precentral gyrus. What about the postcentral gyrus? Postcentral gyrus is behind the central sulcus, and it will receive the general sensations. General sensations like it could be touch, pain, temperature, proprioception, parietal sensory cortex. So it is coming to the parietal sensory cortex, receiving general sensations. Postcentral gyrus behind the central sulcus. Then you will find that when you are opening the lateral sulcus at the floor of lateral sulcus, When you're opening the lateral sulcus, at the floor of the lateral sulcus is the insula. This came as a question also in a transverse section. We'll see insula in a transverse section later, but just have some idea here. And what about the medial view of the cerebrum? If you're talking about the medial view of cerebrum, let's look at that as well, and it is here. You'll find that on the medial view of cerebrum, the central sulcus is encroaching. Though central sulcus is mostly on the lateral surface of the cerebrum, but it encroaches on the medial surface of the cerebrum, separating the anterior frontal lobe, frontal motor cortex, the precentral gyrus, and posterior parietal lobe, that is the parietal sensory cortex. Actually, this is where you have the what do you have? This is where you have the paracentral lobule. Now, if you are telling this is the paracentral lobule, are you trying to say that this is the area to control the lower limb and the pelvis perineum area? Yes, the homunculus, sensory motor homunculus. So, this is the sensory motor homunculus for the lower limb and part of the pelvis perineum. Yes. What if I have a lesion here? I had a question. There was a lesion on the left cerebrum. If you have a lesion on the left cerebrum, the problem will be on the right side of the body. And what will happen on the right side of the body? Sensory motor loss on the lower limb and the part of pelvis perineum. That was their question. Okay. Paracentral lobule, fine. That meningioma question? Yes, that meningioma question. Now, you will find that there is this central sulcus which was separating the anterior frontal lobe from the posterior parietal lobe, but then we have got one calcarine sulcus also, which is evident on the medial view of the cerebrum, and below that will be, actually in the vicinity around that will be occipital visual cortex. Whatever you are looking at, vision comes here. So whatever we look at, the vision comes here, occipital visual cortex in the vicinity of calcarine sulcus, more evident from the medial view of cerebrum. And what is this lobe here? If that was the occipital lobe, occipital visual cortex, what is this lobe here? Do you remember we have discussed Pape's circuit, the limbic system, the hippocampus, cingulate gyrus? This is cingulate gyrus, yes. And that is the hippocampus area, yes. Are you talking about Pape's circuit, which is for emotions and memory? Yes, emotions, memory, limbic lobe. This is limbic lobe. So when you're talking about the limbic lobe, it is some Pape's circuit, and you are telling that there is some hippocampus involved, then there will be some fornix involved, and then there will be some hypothalamus, thalamus, and also cerebrum, the cingulate gyrus. Yes, actually this is the limbic lobe, limbic system, emotions, memory. Okay, let us draw the cerebrum now to discuss homunculus. But before you draw the cerebrum to discuss homunculus, you must know what is homunculus. Homunculus is representation of the body on brain. Which part of brain? Cerebrum. So if you are representing the body on cerebrum, it is actually upside down. What is upside down? See, normally this is head and this is the upper limb, lower limb, isn't it? That is the head, this is the trunk, and then you will see this is upper limb and lower limb. So we have the head, this is the trunk, and this is the upper limb, this is the lower limb, but it is upside down on the cerebrum and in an oblique fashion. So you are telling that the representation of the body on the cerebrum is represented in a homunculus, and which is upside down and in oblique fashion. Why oblique? Because it is along the central sulcus. It is along the central sulcus, and it is both motor and sensory. If it is precentral gyrus, motor. If it is postcentral gyrus, then it will be sensory. You can understand it better in a diagram. Let's look at the diagrams and then draw the diagram also. See, we'll find that hand is having more representation on the cerebrum like the face. So, hand and face will have more representation. Remember, face is on the lower lateral cerebrum and the hand is slightly upper here. You mean to say cerebrum has representation of body and sensory motor control of the face is here? Yes. And hand is slightly higher? Yes. And what is still more higher? Pelvis perineum. Pelvis perineum. Area is here. Let us see the diagrams also. You will find this is two diagrams we are looking at. And what is the orientation? To have the orientation, you will see this is the superior view of the brain. What do you mean by superior view of brain? Like you have put somebody in the CT scan and then you are looking at the superior view of the brain. Oh, you mean to say it is a transverse section of the brain from the superior view of the nose is anterior? Yes, the nose is anterior. That view. So this is the view. Yes. Nose will be anterior. Yes. And then this is posterior. Yes. That is the view you want to have. Yes. Superior view of the brain. So in the superior view of the brain, you will see this is the central sulcus running anterior-inferiorly. As the central sulcus is running anterior-inferiorly, we have seen that there was some gyrus, the precentral gyrus, and it is the frontal motor cortex to control the skeletal muscles of the body. If it is more superior, that will be pelvis perineum area. If it is here, it is the hand area per limb, and if it is there, then it will be the face area. This is called homunculus. Similarly, there will be a sensory homunculus also, which is post-central gyrus, parietal sensory cortex. Parietal sensory cortex, post-central gyrus will have sensory touch the face, and this area will be activated. Touch the hand, and this area will be activated. Touch the pelvis perineum region. Why are you touching the pelvis perineum? I am doing episiotomy. Okay, episiotomy, fine. So episiotomy, you are doing, this area will be activated. Yes, then you have to block the sensations, giving some blocks, pudendal block, all that. Anyway, what is this diagram? It is superior view of the brain. Then what is the other diagram? That is a coronal section of the brain. You are looking from the front view. So this is front view of the brain now, showing homunculus. Yes, actually this will be medial towards the midline, and that will be lateral. So this is medial towards the midline, this is lateral. That is the orientation. Yes, this is the diagram which you want to see. It is front view of the brain. You're looking at the right side of the brain. Now, if this is the front view of the brain and right side of the brain, fine. I got the orientation. Now, what is the detail? See, hand has more representation and the face has more representation. So, you have to tell that on the brain now and start. I told you, if it is lower and lateral surface, then it is face area. Lower and lateral. Maybe it is sensory motor homunculus, but it is lower and lateral. And what if I go slightly higher? Then it is the hand area, upper limb area. Sensory motor control. And what if I go still higher? Then it is the pelvis perineum area. Pelvis perineum area. And where is the lower limb area? Lower limb area is actually on the medial side of cerebrum, and because it is on the medial side of the cerebrum, that paracentral lobule, partly some part of pelvis perineum also encroaching here, you cannot show that on the superior view of cerebrum. Why I cannot show on the superior view of cerebrum? Because you have to separate the cerebrum and look at the medial side of cerebrum, then you can see. So I cannot show the lower limb homunculus here. No, you cannot. Because for that you have to separate the cerebrum and look at the middle view of the cerebrum. That is where you see it. Okay, fine. Now let me draw the lateral view of cerebrum showing homunculus, and then we will see the middle also. And the diagram comes now. As the diagram is coming, you will draw the cerebrum. This is the cerebrum, and you're looking from the lateral view. If this is a lateral view, then this must be the lateral sulcus. And if this is the lateral sulcus LS, then there is a central sulcus also running anterior-inferior. If you say this is the central sulcus which is running anterior-inferior, we have told that there will be a frontal lobe in the front, and then there will be a parietal lobe which is posterior. So, we are looking at the lateral view of the cerebrum, and this is the lateral sulcus, and this is the central sulcus running anterior-inferiorly and separating frontal lobe on the front and parietal lobe posteriorly. Actually, both of the lobes are separated from the temporal lobe by the lateral sulcus. So it is the lateral sulcus which will separate the temporal lobe from the previous two. Previous two are the frontal and parietal, separated from the temporal lobe by the lateral sulcus. Then you were drawing one imaginary line. That imaginary line starting at the parieto-occipital sulcus. And when you start at the parieto-occipital sulcus, this imaginary line you draw down so that you can separate occipital lobe posteriorly. That is occipital lobe posteriorly. Now, once you have that orientation, you can also tell there is a precentral gyrus. If you say this is the precentral gyrus, then that precentral gyrus is frontal motor cortex to control some skeletal muscles of the body, and this is the postcentral gyrus. If that is the postcentral gyrus, then it is behind the central sulcus and it will receive the general sensations, the parietal sensory cortex. So this is the parietal sensory cortex, postcentral gyrus, receiving general sensation, could be touch pain, temperature, proprioception, etc. Proprioception also come here. Now, once you have told that, what about the homunculus? If you are talking about the homunculus, we'll see the details now. But you should also understand that this is going to be occipital visual cortex. In the vicinity of calcarine sulcus, there will be occipital visual cortex, though the calcarine sulcus will be more clearly seen on the medial view. And what will be the temporal auditory cortex? This is the temporal auditory cortex. Whatever you are listening to is coming to the temporal auditory cortex. Deep to the ear, temporal auditory cortex. Now, once you have that orientation, talk about the homunculus. As you are talking about the homunculus, this is head and trunk. If that is the head and trunk, then where is the upper limb, lower limb? This is upper limb and lower limb. And now represent the upper limb, lower limb on the brain, the homunculus. If you're talking about homunculus, I'll tell you that this is the head area and this is the upper limb area. Now, if you say this is the head area and that is the upper limb area, where is the lower limb area? Lower limb area you cannot see. Why? Because you're looking from the lateral view of cerebrum. If you want to see the lower limb area, then you must see on the medial side of cerebrum. What you can see here is part of the pelvis perineum. Pelvis and perineum. So partly pelvis perineum is seen here, sensory motor area. So what is the importance of knowing the homunculus, which is represented along the central sulcus in an oblique fashion upside down? The homunculus is represented along the central sulcus obliquely and upside down. It is importance is, if I have ischemia here, then there will be sensory motor loss on the face. If you have ischemia here, then sensory motor loss on the upper limb. And if you have ischemia here, sensory motor loss on the pelvis and perineum. And what about the lower limb? Lower limb you cannot show here in the lateral view of cerebrum. You have to draw the medial view of cerebrum. Let's do that now. And as you do that, medial view of the cerebrum, there you can show the paracentral lobule, lower limb area. And let's do that. You are now looking at the cerebrum, but this is going to be the medial view of cerebrum. Now, if it is the medial view of the cerebrum, that is where you will find that central sulcus is encroaching slightly. And as the central sulcus is encroaching, it will separate the frontal motor cortex and the parietal sensory cortex on the medial side of cerebrum also. That is where you are having the paracentral lobule. If you remember, we have discussed earlier one patient with meningioma. So you are telling that central sulcus is encroaching on the medial view of the cerebrum. Yes, separating frontal motor cortex. Frontal motor cortex from the parietal sensory cortex. Parietal sensory cortex for what? For the paracentral lobule, which is for the lower limb and part of the pelvis perineum. If you have ischemia here, then contralateral body will have sensory motor loss on the lower limb and part of pelvis perineum. And what about this sulcus here? This is the calcarine sulcus we were talking about. And when you are talking about the calcarine sulcus, which is evident on the medial view of the cerebrum, that is where you have the occipital visual cortex that we have discussed earlier as well. Now, fine. If that is all you wanted to tell here, Let's move further, and we want to talk about broadband numbers. There are some broadband numbers which we have to remember because examiner is asking frequently. So let's do that. You are looking at this diagram, which will repeat some information and add some more. You see, this is the precentral gyrus, which is area number 1, 2, 3. So precentral gyrus is area number 1, 2, 3. We'll draw a diagram and show it ourselves as well. This will be the postcentral gyrus, actually. Postcentral gyrus. So you're telling this is postcentral gyrus, the parietal sensory cortex receiving journal sensation. Yes. And what is area number 4? Area number 4 is precentral gyrus. Area number 4 is the precentral gyrus, is frontal motor cortex. If you activate that area here, pelvis perineum will move here, the hand will move here, then the face muscles will move. Homunculus. You remember the homunculus. And what is the area number 17 for? Area number 17 is occipital visual cortex. Whatever you're looking at will come here. Occipital visual cortex. And whatever you're listening to, go deep to the ear. That is area number 41, 42. Area number 41, 42, the superior temporal gyrus. So there is a superior temporal gyrus area number 41, 42. Whatever we are listening to, go deep to the ear. What about the area number 8? Frontal motor cortex. Actually, there is a frontal eye field. Frontal eye field. Now, when you're talking about frontal eye field, area number 8, what is it for? And what if it is having ischemia? It is to control the horizontal movement of the eye simultaneously. Means if one eye is following an object, the other eye must follow it accordingly. Lateral rectus coordinate with medial rectus. That is controlled by this area. Let us talk more about this now by drawing a diagram. And this is our diagram. So let us do it. And what you are drawing is the cerebrum lateral view. If you draw the cerebrum lateral view, then this must be the lateral sulcus. Yes, that is the lateral sulcus. If that is the lateral sulcus, then that must be the central sulcus. Yes, that is the central sulcus. Then I think there will be area number 1, 2, 3 behind that. Yes, that is area number 1, 2, 3 behind that. And that is the post-central gyrus. And what is this post-central gyrus for? It is actually the parietal sensory cortex. And what do you need the parietal sensory cortex for? It is to receive the journal sensation. And journal sensations could be touch, pain, temperature, or proprioception also. So you are telling that this is a central sulcus, behind that is some post-central gyrus, area number 1, 2, 3. Yes, post-central gyrus, area number 1, 2, 3, which is parietal sensory cortex to receive the journal sensation. If you are touching the face, this area is activated. If you are touching the upper limb, this area activated. If you touch the pelvis perineum, that area activated, homunculus. And what about the precentral gyrus? If you are talking about the precentral gyrus, it is area number 4. And area number 4, which is pre-central gyrus, it is the frontal motor cortex. And that frontal motor cortex, if you activate, there will be some skeletal muscles moving. So you're mentioning that in front of the central sulcus there is area number 4, which is the precentral gyrus, which is actually the frontal motor cortex and which is to control some skeletal muscles. Skeletal muscles of what? It depends. If you activate this area, face muscle, that area, upper limb, that area, pelvis perineum. Homunculus, motor homunculus. Then what about the vision? Where is the vision coming? Vision will come to area number 17, and as you're talking about area number 17, that will be occipital visual cortex, whereas the 41, 42 is the superior temporal gyrus. It is also called as Haschel gyrus. Haschel gyrus. One of the Jipmer question asking Haschel gyrus. Remember, if you're looking at something, that vision will come to area number 17, which is occipital visual cortex. And if you're listening to somebody, then it will be the temporal auditory cortex. And where is the temporal auditory cortex? Temporal auditory cortex is actually the superior temporal gyrus. You mean to say there's a superior temporal gyrus, there is a middle inferior also? Yes, actually there's superior, there's a middle inferior. So you're telling that there is a superior temporal gyrus, there is a middle temporal gyrus, there is an inferior temporal gyrus. Yes, like that. Like that you have this superior frontal gyrus, middle frontal gyrus, inferior frontal gyrus. So there is a superior frontal gyrus, middle frontal gyrus, inferior frontal gyrus. Yes, what is there then? Let us discuss. But remember, whatever you're listening to, come to area number 41, 42, which is also called hasal gyrus, and it is the superior temporal gyrus. Now, middle temporal gyrus, area number 8. Area number 8, I remember area number 8. It was some frontal eye field. Yes, frontal eye field. So you are telling that area number 8, which is frontal motor cortex, is middle frontal gyrus? Yes, middle frontal gyrus. Now this is the middle frontal gyrus where you are showing the frontal eye field. What is frontal eye field for? Frontal eye field is to make sure that medial rectus work with lateral rectus. What is medial rectus, lateral rectus working together? That is actually horizontal gaze. You are talking about the horizontal gaze. What is horizontal gaze? Means one eye should follow the other eye. Like you are telling the patient, follow my finger to the right side. Both eyes will follow. Which muscle working on the right side? Lateral rectus. And which muscle working on the left side? Medial rectus. They must work together. So both eyes must follow the object to the same side. And what if I am following it to the left side? Which rectus working on the left side? Lateral rectus. And then which rectus working on the right side? Medial rectus. The medial rectus should coordinate with lateral rectus. How do you manage that? That is frontal eye field, area number 8. Remember, it is the left frontal cortex which will make sure the both eyes follow object to right side, contralateral side. You mean to say if I have a lesion in the left frontal cortex, then the eyes cannot follow the object to right side? Yeah, that is a point. There will be a diplopia and nystagmus. Then remember, it's the left frontal cortex which is controlling the movement towards the right side and contralateral side. If I have a patient with lesion in the left frontal cortex, patient cannot follow the object to the right side. Means right-sided lateral rectus is compromised and consecutively the left-sided medial rectus gets compromised. There are many things actually. There will be a PPRF, there will be a MLF. What is this PPRF, MLF? Actually, parapontine reticular formation and sixth nerve. And for the sixth nerve, it is the medial longitudinal fasciculus to the third nerve. Why third nerve? Because medial rectus. And why sixth nerve? Because lateral rectus. You mean to say left frontal cortex is sending some parapontine reticular formation to control sixth nerve here to control lateral rectus? Yes. And then the sixth nucleus is controlling medial longitudinal fasciculus towards the left side to control medial rectus muscle? Yes. This is all starting here. Okay, what is the next thing? Next thing, you have to talk about language processing. See, if this area is compromised, there can be diplopia and nystagmus. That is a long detailed discussion. We will not do it here. But now what we do is, we are talking about the language areas. Like what? Like you are giving a task to the patient. You are giving a task to the patient. Patient, you are telling, what is this? Patient will look at the word. He'll understand the word and then speak out the word. This is your task. So give the patient a task. What is this? Read it aloud. Let us see what happens now. So what happens is that patient has to understand what is written. Anatomy, he has to understand by Wernicke's sensory speech area, and then he'll use arcuate fasciculus to communicate it with the Broca's motor speech area, and then he will be articulating the speech muscles and speak out anatomy. Doctor, you have written anatomy. You mean to say, first he will see it at area number 17? Yes. And then it will come to area number 22, which is for understanding of the language? Yes. And then there will be some arcuate fasciculus taking it to Broca's. What is Broca's area for? Plan the speech muscles. Speech muscles means what? Means tongue muscle, lip muscle, larynx, pharynx muscle. Let us look at the more details. This is the diagram. So you have to understand, when you give a word to the patient to speak out aloud, this area number 17 will be activated to look at the word, and after that 22 will be activated to understand the word, and then area number 44 is activated to plan the speech muscle, and then area number 4 will be activated to move the muscles of speech. This is the diagram which we are going to draw now. How is it? What is the pathway? Area number 17, after that it is area number 22, after that it is area number 44, and after that it is area number 4. This is the diagram which we are supposed to draw. Let's do it. So this is the diagram you are going to draw now, giving a task to the patient to speak aloud something written there. Yes. Okay, do it. So this is the cerebrum again. Yes. And this is the lateral sulcus again. Yes. Now you are telling this is the central sulcus, of course, running anterior-inferiorly, central sulcus. Then you are telling that you gave a task to the patient and telling this is some word, read it. Yeah, some word, you read it. What happened after that? What happened after that? Patient saw it and area number 17 was activated, occipital visual cortex. So occipital visual cortex was activated now. Yes. Then what is activated? This. What is this? Area number 22. What is area number 22? It is actually Wernicke's sensory speech area. If you say it is a Wernicke's sensory speech area, what is the Wernicke's sensory speech area for? Actually, it is for the comprehension of language. What do you mean by comprehension of language? Comprehension means understanding of language. Okay, so this is the area which will help me understand the language. Yes. And which area will be activated after that? Actually, we need a fasciculus now, which is called as the arcuate fasciculus. AF is arcuate fasciculus. It is some arcuate arc-shaped bundle of axons. Arc-shaped bundle of axons. Fasciculus means bundle of axons. So there is some arcuate fasciculus connecting area number 22 with area number 44. Double the number. You mean to say 22 into 2 is equal to 44? Yes, not only 44 but also 45, and this is inferior frontal gyrus. Oh, like there was a middle frontal gyrus? Yes, that was middle frontal, but this is inferior frontal gyrus. So this is inferior frontal gyrus where you have the area number 44, 45. This is the Broca's motor speech area. Fine. Can you tell me where is the Wernicke's area then? Motor speech area is here. Fine. So area number 44, 45 is inferior frontal gyrus, understood. It is the Broca's motor speech area, understood. But where is the Wernicke's area? Actually, that is a controversy. But still you will follow Harrison medicine and tell it is the superior temporal gyrus. But if it is superior temporal gyrus, I already had something on the superior temporal gyrus already. Yeah, but that was more anterior. If you are talking about temporal auditory cortex, it was more anterior. You mean to say superior temporal gyrus only, more posterior is the Wernicke's area? Yes, it is the same superior temporal gyrus, but more posteriorly it is area number 22, which is superior temporal gyrus only, and Wernicke's sensory speech area for understanding of language. Then what is the area number 44 for, 45 for? It is to plan the speech movement. If you're telling this is planning the speech muscle movement, just planning, yes, just planning. Can you tell me some speech muscles? Yeah, maybe the tongue muscle, maybe the lip muscle, maybe the larynx, pharynx muscle. They are all involved in speech. So you are telling that you have to plan tongue muscle with the lip muscle, larynx, pharynx, otherwise there could be a problem with the fluency of language. Yes, it is maintaining the fluency of language. Broca's area is to maintain the fluency of language by articulating, planning the articulation of the speech muscles. So Broca's area is maintaining fluency of the language by planning the speech muscle. What if it is not planning properly? Then there will be speech problems, difficulty of articulation, compromised fluency of language. Once it has planned, what will happen? Then the area number 4 will be activated. And what is area number 4? That is the frontal motor cortex. It will move the muscles of the lip, tongue and larynx, pharynx, whatever. So you're telling that now the area number 4 will be activated, which is the frontal motor cortex, and then it is going to move the muscles of the lip and the tongue, larynx, pharynx, and the patient will speak out anatomy. Yes, then he speaks out anatomy. See, when you shown the subject this word, you gave a task to the patient, read it aloud. And which area activated? First the area number 17 and then area number 22 for understanding. Then it was area number 44 and then it was area number 4 and the patient spoke out the anatomy word there. What if I have a lesion in the Wernicke's area? If you have a lesion in the Wernicke's area, then there will be a sensory aphasia. And how will you identify a patient of sensory aphasia? These patients are very talkative and they talk nonsense. They are very talkative and they talk nonsense. But why they are talking nonsense? Because they have loss of insight. They have loss of insight. They don't know that there is a problem with them. They think the problem is with you, not them. So you are telling that if there is some ischemia in the area number 22, then there will be some Wernicke's sensory aphasia. Yes, and very talkative patients and talking nonsense. Maybe they're talking nonsense because they don't know what they're talking about. The understanding of language is gone. So understanding of language is gone. So they don't know what they're talking about. No. So they keep talking about something. Yes. And very talkative. On the other hand, the Broca's motor aphasia patient, if a lesion is here, there's a Broca's motor aphasia patient is mum. Means hesitant to speak. But why they are hesitant to speak? Because there is a compromised fluency of language. There is some problem with articulation of the muscles of speech. So if a lesion in the inferior frontal gyrus, there is a Broca's motor aphasia. Yes, and the patient is mum. What is mum? Is hesitant to speak. Less talkative. Why? Because there is a problem with the articulation of the speech muscle. Fluency is gone. And what if I have a lesion of the arcuate fasciculus? If you have a lesion of the arcuate fasciculus, it is called conduction aphasia. And what is how I identify the conduction aphasia? Conduction aphasia is presenting with the poor naming, and it is presenting with poor repetition of language. But if you say it is poor repetition of language and poor naming due to lesion of the arcuate fasciculus connecting area number 22 with 44, if arcuate fasciculus is compromised, one of the aims question it came, and it is conduction aphasia with poor naming and poor repetition. I have these two clinical features in other patient also. Wernicke's aphasia also present with the same. Broca's aphasia also present with the same. How will I know that it is not Wernicke's aphasia? Because there will be intact comprehension. And how will I know that it is not Broca's aphasia? Because patient will be hesitant to speak, fluency compromised. See, understand, all the three aphasias, maybe it is Wernicke's aphasia, maybe it is conduction aphasia, or maybe it is Broca's aphasia, they have same problems. What is that? They have poor repetition and poor naming. But if all of the three have same problems, then how do I know which one is which? Simple. If there is intact comprehension and intact fluency, then it is conduction aphasia. And what if it is compromised comprehension of language, very talkative patient, then it is Wernicke's aphasia. And what if it is less talkative? Then it is Broca's aphasia. I will show you a table also. In that table you can see about the aphasias. There are some questions coming frequently, so that's why we need to have some details. Like if it is Broca's aphasia, it is called expressive, it is non-fluent, fluency is compromised, comprehension is intact. If it is Wernicke's, which is receptive aphasia, the patient is having fluency, but the comprehension is compromised. Wernicke's. But if it is conduction aphasia, they have good fluency, they have good comprehension. The problem is with the poor naming and the poor repetition. Problem was in the arcuate fasciculus.